Healthcare. We have a panel that represents a tremendously diverse range of expertise. Amir Khan, who is director, I think president, is that right now, of Lokal University, which is in Uttar Pradesh, a major technology and engineering school in India. Lipo Ra, CEO of the Yen Foundation, which we heard about this morning. Also a very significant not-for-profit entity here in Singapore. Josephine Price, director of the Village People Project, which is a fascinating initiative in China involved with the provision of bathhouses, washing facilities in rural parts of China. And then John Forsyth, managing director of Viva Healthcare, which is a global healthcare network providing primary care services to many parts of the emerging world. So, can I ask speakers to join me up here? We'll get started. So I'm going to give a few introductory remarks, just sort of setting the stage about, at least from my perspective, what the challenges are facing this part of the world in terms of healthcare. And then each of the panelists is going to speak about their own work in this area, the challenges that they face and the solutions that they see, and we'll open up for broader discussion. So, from a purely population perspective, there's about 4 billion people in Asia today, and more than 3 billion of them don't have access to essential healthcare. And so by essential healthcare, I mean the sort of care that you need to treat or prevent the diseases or the conditions that are most likely to kill you or disable you in youth or in middle age. And if we look at what are those causes of death and disability, they largely break down into two areas: heart disease, stroke, diabetes, lung disease, which are chronic conditions that now affect every country in the Asian region and are in fact what we cause death and disability in those countries. And then the other conditions marked with an asterisk, which really represent the traditional diseases and conditions of poverty, such as birth complications, TB, diarrheal diseases, etc. And many countries in Asia, India is a perfect example, Indonesia another example, really are suffering this double burden. They have all the traditional diseases of poverty, and in addition they have all of the new diseases of development. Often within a healthcare system that was struggling to provide care for the old diseases, they now have to try to deal with this double burden. So just to give you an example of, I guess, what can go wrong with this enormous burden. This is work we did in rural China, and we studied a large population there, and we identified about 2,500 people who had a stroke or who had a heart attack. And we asked the question, what sort of treatment are people receiving? And you can see here that even if you had a heart attack, only 1 in 6 people were taking an aspirin. Okay, and that's got nothing to do with the cost of aspirin. Obviously, it's very cheap even to the poorest. In the poorest populations, it was available everywhere, but there was no health system, no functioning health system, which even for someone who had a heart attack could give them an aspirin. And the situation was even worse for stroke. And this is not a unique finding. It might have been the first, but subsequently many other projects have observed the same thing. The truth is that today in Asia, if you have serious cardiovascular disease, you're most likely to be receiving no treatment at all. And that would really be true of almost any major chronic condition. That's the current situation that we face. And that, I think, from my perspective, above all, is the challenge that we need to address and that we need to think about innovative ways to deliver care for those who have not only poor access, but no access at all. So why are we in this situation? Well, I think it's very clear that existing health systems are weak. that although governments and not-for-profit organisations have been actively working around Asia, we still have public health and clinical care which is substandard by any stretch of the imagination. It's still very poorly resourced. It's unaffordable, and as we heard this morning, much healthcare is still out-of-pocket expenditure in Asia. There is virtually no quality control, so there's enormous variability between the sort of care you would get in one town versus another, or from one doctor to another. The system is, or the operation of clinics is often dysfunctional. In India, 50% absenteeism from primary healthcare centres is the norm. And as a consequence of all these things in many places, China's a good example, community health in particular is not respected by the community. People will drive 3 hours, perhaps 3 days, to get healthcare rather than see the local doctor. So what is the solution? My own view is that the solution is not fine-tuning the system that we've got today. The system that we've got today is completely broken, and I think we need really radical change if we're going to prevent hundreds of millions of people dying unnecessarily over the next couple of decades. I think we do have to look at healthcare from the frugal innovation lens, because we have to have sustainable solutions for people living on very low incomes. The current models of care we've got, which in part are developed from the British and American and Russian and German models, are unaffordable in those countries, and they're certainly unaffordable in most of Asia. I think the innovation needs to be, on the one hand, about services. I think it also has to include technologies, drugs and devices, because what's available for populations in China or India or elsewhere in Asia isn't necessarily what is needed. It's what is there, but it's not necessarily what's needed. And there's been very little innovation in therapeutics for emerging markets, and I think that's something that has to change. And perhaps of greatest importance is that we need new financing systems. We can develop fabulous new models, but if there's not a financing system, insurance scheme, for example, to support it, then they won't work. And I think overall, healthcare and the biotech industry as a whole for low-middle countries has to change from a very low-volume, high-margin model to something that's much more appropriate to these populations, which is low-margin, high volume. Still profitable, of course, but a different model to that which has made Pfizer and Johnson & Johnson their fortunes in the West. And I believe that the solutions, of course, have to involve government, but I don't think government alone is going to necessarily come up with the solutions. Certainly, they haven't been able to do that today. So finally, what might venture philanthropy or impact investment contribute to this area? Well, I think that given that we're talking about innovation, we're talking about entirely new approaches to healthcare, early stage investment is going to be very difficult to obtain, and I think there is potentially an enormous role that venture philanthropy and impact investment could play in that early stage of investment, basically developing fit-for-purpose solutions that are sustainable and scalable, ideally that have a short time to market because the urgency is great. And I think we need funding for research and development. We need to be able to prove the principle that frugal innovations deliver what they're supposed to and are affordable. We need to help people develop business plans to roll these out. I think there is a crucial need for mentorship in developing social enterprises that are going to deliver these services and products. And I think that venture philanthropy could also play an important role in introducing young health entrepreneurs to investor networks that might allow these developments to be scaled up. So that's the background that I'm going to give, and I'm going to turn it over now to each of the panel members to make a comment about these issues from their perspective, and I'll start with Amir.
Thanks, Bill.
Thanks, Stephen.
Well, there were two things that Stephen said
that I remember, one that I agree to completely, and one that I disagree heartily. The one that I agree to is on the solutions that Stephen detailed, right? Spot on. Remember, he told you about heart care and said that if you have a heart condition in Asia, then about half of you will not get treated. Stephen, that's not the issue. The issue is that the other half who gets treated will die, because the quality of that care is abysmal. It's better off not getting treated. Right. So I'm not talking of Singapore, right? And a few other countries who are represented here. Alright, so now I've got your attention. There were two or three very simple points that I want to underline here before we go into the discussion. The first is that I cannot but underline what Lawrence here in the morning talk said about the neglect of upstream activity. It is nowhere as bad as in health. The other chart that I will invert in Stephen's presentation is the chart which showed the top 10 diseases in India. If you look at the poorer countries in Asia, then it's exactly the other way around. It is lung and heart and whatever at the bottom, and simple, stupid diseases like tuberculosis and pneumonia that kill the larger number of people. And that's largely because we have done nothing in terms of upstream activity in these diseases. My favorite example in my entire career, and I learned all that in my career with the Gates Foundation, is this brilliant case study on polio. What is the polio case study? Polio is this large killer in the first half of the 20th century. Everybody is dead scared of polio. And then somebody comes along and invents this vaccine, and everybody starts getting treated, and it becomes a really no-brainer. So most of the West forgets about polio. But polio is still a big killer in Asia. In 2009, India is the country that everybody is scared of, that this is going to be the country that is going to continue to supply polio to the rest of the world, and it will not finish the polio virus. And then something happens in India. In 2 years' time, there is no polio. The country which has the largest incidence of polio manages to, with all its complications, problems, lack of money, etc., to finish off polio. Now, the only countries where we still have polio, which still threatens all of us, are Afghanistan, Pakistan, and Nigeria, and there is a lot in common to those three countries. So the polio example shows that where we invest enough, where we think enough, then we are able to completely wipe out such large diseases, which have stood the test of time. So the big point I'm making is that we who work in the healthcare sector find a very ready parallel in the education sector, and we are very envious of what happens in education. The education activists seem to have understood the problem in education. Government seems to have got their act together in education. People realize that there is return on investment if you invest in education, but that is not true of healthcare. There is not enough investment in healthcare, and I have these. If you look at that, then you will find that all these countries, which are really the problem countries of the world, spend very little on health. And contrast that, and I'm not talking about the big Western countries, just contrast that to South Africa, Mexico, Russia. You will see there's a huge difference in the spend on healthcare. Right? Don't bother reading, I'm just showing you this graph to show this the huge difference that exists. And I'm not putting Singapore here at all, otherwise the graph gets distorted. Right? Now look at how much we spend on healthcare. We, as the venture investment philanthropy community, the foundations, the donors, and I just want you to focus on India. Oops. Just focus on India. What I'm showing here is that all of us together. The DFIDs, the USAIDs, the Bill Gates Foundations, the Bill Clinton Foundation, all of us put together spend less than 1% of all development expenditure in India, right? Of which health constitutes 0.1. So that's the big question. That when we spend that little, we obviously count for a lot in Mozambique. In Mozambique, when we speak, then everybody listens. And we can tell governments in Mozambique and Malawi that a pentavalent vaccine or a vaccine against polio or a vaccine against pneumonia is good for your children. In India, nobody is going to listen. And that's our big challenge. That in countries like India, where and I'm speaking not just of India, but I'm talking about a lot of countries in South Asia and Africa, it is very difficult to talk to governments on increasing expenditure on health. They will do that for education, they will not do that. And the reason for that is that health by itself is a very complicated, difficult sector. It has a huge number of vested interests. In China, India, generic manufacturers, etc., etc. It's a big issue. So therefore the challenge is much bigger. And that is why, for those of us who want to see impact, it is very critical that we be very specialized when we talk about healthcare, because that is where one can prove where the biggest bang for the buck comes from and get people to invest in those areas. One simple area in which the largest return on investment comes is vaccinating children, and you will find large numbers of children unvaccinated, and therefore take the example of North India, 3 million children dying before the age of 5 just because somebody has not spent that $1.50 to vaccinate. And the irony is that in countries like India, China used to be like that a few years ago. The ironical situation in India, 50% of world's vaccines are manufactured in India, and 50% of Indian children are not vaccinated.
I'm not a policy wonk, I'm just a social worker, so I need to show you some visuals. Okay, this is the National Cancer Hospital in Hanoi. It's a 500-bedder. 1 year they serve 15,000 inpatient, another 15,000 outpatient as well. It was a surreal experience for me when visiting this hospital. This old colonial building, you see all these chemo patients carrying their drip bags walking around. In a typical ward, this is how it looks like. 2 adults sharing 1 bed. If you go to the children's oncology ward, we have 4 kids sharing 1 bed itself. The corridors are overflowing because typically these patients come from the rural villages. So their caregivers, their family members have to accompany them. They actually physically stay inside the hospital. But what is shocking and unthinkable is that this hospital don't have enough water. To the extent that the family members have to go outside to purchase drinking water for the cancer patient. We did a water audit and also found that the hospital water is actually contaminated. So think about the doctor who's washing his hand or her hand just before surgery. He's actually jeopardizing the patient's safety. So only when you see such stark reality would you better appreciate your country's national healthcare system. So it's a very simple solution and intervention on our end. So we overhaul the whole water management and treatment system. Put in place additional storage tanks, sunk a bore well to boost the supply, installed 70 wash basins and drinking fountains, and you can drink straight from this water fountain in Hanoi, whereby cholera outbreaks still happens. So it's a modest sum of investment to enhance patient safety and well-being. So why is the foundation so fascinated with water and sanitation? Because I do think that it is the fundamental to human health and the foundation for human development, without which no country can escape from poverty. Can you name me a developed country where you can't drink straight from the tap itself? In 2007, the British Medical Journal, they actually did a poll asking their readers, what do you think is the most important medical milestone since 1840? That was the year that the British Medical Journal started. So 11,000 of their readers responded. These are all doctors, healthcare professionals. Water sanitation came in as number 1, ahead of the discovery of antibiotics, the development of anesthesia itself. I think philanthropy at a fundamental level is an expression of values. So we believe that those in the shadows of death deserve better. These are some of the weakest, sickest, most vulnerable, and very often voiceless members of our society. Death is inevitable, but severe suffering is not. In a world that worships longevity, we must never forget the needs of the dying itself. But I find that a lot of our healthcare system, they have become obsessed with diseases, with medical technology. They have forgotten their mandate to alleviate suffering. So, in need to improve care for the dying, the foundation has done some work on the supply side of things itself, palliative care research and training. Some examples. This year we are working with the Ministry of Health in Myanmar and Bangladesh, and of course the healthcare professionals to develop their palliative care expertise. And in 2010, we commissioned the economists. These are the folks who developed the quality of life index. We got them to turn the idea on its head, to come up with this quality of death index, which ranked 40 countries on their provision of end-of-life care. And I must say, never underestimate the power of research and ranking itself. The report has been used by many parties all over the world to lobby the government to improve end-of-life care, to fight euthanasia, to secure vital pain medication. And it's also used by some academics in medical school, nursing school as their teaching tool itself. So we also believe that we will not succeed unless all of us here know what is good end-of-life care and demands it itself. Which is why we have also done work on the demand side of things itself. And on this Life Before Death campaign, our objective is to spark dialogues, conversation on end-of-life issues itself, and of course to promote hospice palliative care. We have done over 30 initiatives since 2006, including like 7 films. So with greater death knowledge, we want people to re-examine, redefine, and hopefully reclaim their life before death. So some of you may be wondering, what is the foundation philandering in IT? Because I really see that healthcare, if you look at it, is really an information-based industry that needs a strong IT backbone to orchestrate, to improve the quality and delivery of patient care. IT is a tool to inform, to support better decision making for clinicians and admin staff who's doing work at the front line, close to the patient itself. And in my opinion, I think all healthcare institutions need to view IT as a tool for the competitive difference. So we have done some projects over the years. The first one is 2006, where we work with HCA Hospice Care. They are the biggest player in terms of home hospice care. Their market share of 90%, 30 over staff. They do about 30,000 home visits a year. So we put in place a mobile system. It's really an electronic medical patient record system itself. Eliminated tons of paper. The recent initiative is what you see below, whereby we are putting 7 nursing homes on cloud computing. And these are not just ordinary nursing homes, these are market leaders. In totality, they constitute 20% of the nursing home beds in Singapore itself. And we also empower them in mobility solutions. We provided each of these organizations with 30 iPads and 10 to 15 BMWs. These are not a car, but the kiosks that you see on the bottom right hand corner, the bedside mobile workstation itself. In terms of impact, in this whole exercise, we have eliminated more than 100 paper forms. You think about it, 100 paper forms. The labor productivity savings is about 10%. That's very significant because labor in a nursing home constitutes 50 to 60% of the overall cost structure itself. And IT, in a way, have helped transform the work of doctors, nurses, social workers, occupational therapists, physical therapists, even a pastor, and all the admin staff inside the organization, simply because they are able to have the right clinical information or admin information at their fingertips at the right time itself. So I must say that this project we call it INGER, is a home run for us. It is really about using IT to stretch the capability, the potential, and imagination of healthcare engineers.
Good afternoon. Village People Project, we're a very, very small Hong Kong charity, grassroots. We have half a person full-time, the rest of us are all volunteers. It stemmed from understanding or trying to understand the needs of a few villages which are based on the border Gansu and Shanxi province, which is on the old Silk Road west of Xi'an, where we have friends and we visited. They were very poor. We sat, we had lots of cups of tea, we ate lots of noodles, which are abundant there in chilies, and we talked to the village people, and one guy came up to us by June and said, I'd like to build a bathhouse, because there was no bathhouse in the village. There was nowhere for people to get washed. And we had talked to a number of the village doctors, and everyone seemed to believe, and I stress this idea came from Laju, putting a bathhouse in a village where people couldn't otherwise wash. And the nearest commercial bathhouse was 20 minutes on a motor scooter, and was looked really horrible and disgusting, was probably going to do some good. So the village doctors encouraged this. People would otherwise get showered about once a year, typically before Chinese New Year, or a wedding. People would go off in a big party to go and have a shower. This is the way people live. So you can imagine when you speak to the health workers, and I'm not a medical practitioner, so my apologies for all of the knowledge around the table. They would talk about the level of chronic infections that people suffer simply by not being able to keep clean. So we started to build bathhouses. That's one. And typically, the villagers have got an outside standpipe with cold water, which freezes in the winter because this is very cold. So if you want to get washed, it can be very, very difficult. But getting washed, and actually this is the lady who operates one of our bathhouses with her child. They're helping you. One of the nicest things to start your day is a hot shower. We know how good you feel after that, so you can share that experience. I don't think we need to have too much explanation of that. To put it into context, now we're looking at another site. This is Pinto. This is the commercial bathhouse. This is the pictures of what is available to serve a small township, 25 surrounding villages. This is the only bathhouse. That's the electricity. This is the sign. I think it also says Mahjong no karaoke. Yeah, my Chinese is not very good. You can just see the quality, like the pictures we've seen of the hospital. It's quite dispiriting. You want a bathhouse, you come out. That's what's available. Some houses have got their own private showers now with solar heating panels, but these only work in the summer. So in the winter, everyone's got the same problem. And this is what's available. So we have a look at this, and so generally we go around and we look, and then we partner with a local entrepreneur. We provide the infrastructure, and they operate it, and we do a profit share based on a number of factors, including community service and how many preventive showers they've delivered. So our 4 bathhouses operate profitably just. They cover their maintenance costs. We estimate it's costing about 2 RMB 20 to deliver a shower, depending on how much solar we can get from that. And we're charging between 4 and 5 RMB for that, and a lot are free. So school children get 1 free shower a month, older people, it's free, younger people, it can be free. So our model is a very simple one. It's just build something which local people asked for. We didn't come along and say, you should have this. They said, let's do this. The other village said, oh, they've got one, can we have one? Our challenge is that village life is changing in China. I've been going up regularly for a number of years. Populations are decreasing, road access is a lot better, and our challenge is to see if we can take a simple solution but keep up to speed with what's happening in China. So this is a very, very simple solution to improving some of the incidents of chronic healthcare and enabling children to get into the habit of washing, keeping themselves clean, and to give anybody who feels that they need a shower the ability to go and get a shower. So we can have one move on from that horrible picture to the nice picture at the end, which is we have a small community thing at the front where people can talk and chat before they have their showers. It's a bit of a social event. If you go once a month to a shower, you bring your friends, have a bit of a party, try out the latest nail varnish, and the men will actually smoke in the shower. It only happened in the village in China. It is a social event, so there's a social space there where we can have cups of tea, and we try and encourage other things. We're trying to get maybe the Women's Federation to do some trainings there. So it's a very small initiative. It hasn't cost us a lot of money. It costs about 250,000 RMB to put one of these up, which is not huge, but it makes a lot of difference in the villages. So I think what you're seeing is a range of different solutions to improving. Our mission is to improve the health and well-being of women and children in rural China. So we found this to be a relatively simple, straightforward solution to that, and it can link in, I think, with a lot of the other initiatives that we're seeing in terms of improving the rural health equation, because these are the people who do get forgotten. These are the people who, the government builds a swanky new hospital, but it's a long way away, and they are stuck with the same quality of healthcare support.
Hi everyone, John Forsyth from Viva Healthcare, where I'm the Group Managing Director. Viva Healthcare, I'll just focus you a little bit really. What I'm trying to talk about today is what is possible. I'm going to be a slightly rebel today, slightly unconventional. First, it's I'm wearing a tie. Secondly, because I don't have any slides, which you might like. Viva Healthcare focuses on the aspiring middle class. So those who have the ability to pay, so not the very poor, but not those with a lot of money. So we're not looking at the premium end at all. We focus only on frontier and emerging markets. So we've looked across South Asia, East Africa, and North Southeast Asia as well. In the last 3 years, we keep that sort of time span in our head, we've built and opened 14 companies in 10 different countries. We've been pretty rigorous, some might say ruthless, about shutting down things that aren't working, or where they're going to sap a little more of our energy than is required. We've ended up with 7 companies in 5 countries. We put all of our profits back into those businesses. We don't take any of the money out. We're backed by a person with Richard Chandler with a very strong philanthropic and social aim, but our means are entirely business. So our means are entirely venture capital or private equity. We don't have an exit. That is not our plan. The aim was always to keep our businesses so that we would keep them permanently for 100 years if necessary, and build our scale to affect the people that need it most. At the moment, we see the area where you can do business, and the lowest addressable market to do business in is that just above the really, really poor, where you could be accused of taking food off the table if you try to charge people for those services, and that's where I think really government, NGOs, grant making comes in. I'll give you an example of one of those businesses. So in Indonesia, we have a company called Viva Generic. Viva Generic is a generic pharmacy chain. We started it 2 years ago. The young man, who was an Indian Indonesian, had a very sharp guy, went to Harvard, came back to Indonesia where he's from, came with a business plan. He said, I looked in Mexico, they've got 5,000 generic pharmacy chains. I looked at the Philippines, they've got 1,000 there. We don't have this in Indonesia, we've got 280 million people. So this is my plan, can I come on board and try this? And just 2 years later, we have 140 generic pharmacies, not in Jakarta, but in East Java and around Semarang. We open 10 months. They break even in 6 to 9 months. They do very well. We employ about 800 people. We treat tens, now hundreds of thousands of people at a time. There wasn't that service there before. It's entirely affordable. So what I'm saying a little bit today, being slightly controversial, is particularly in healthcare, you can do it. There is the ability to scale. There is the ability to make good returns on that, depending on what scale of the spectrum you're on. On the other hand, it's high risk and it's really hard work. Okay, and in Vietnam, where I spent a lot of my time doing it myself, and that's sort of how my background is not healthcare. I was actually a soldier and I worked in a leadership in a chocolate factory before moving out here. So I have a very different background to most people. But you can do it. In Vietnam, corruption stopped us, plain and simple. $50,000, we put $2-3 million into that country. We were building out wonderful polyclinics, lovely sort of 5-10 doctor specialist clinics, very high quality, sort of in the outskirts of Ho Chi Minh City, at a mid-market price point or below, using only Vietnamese doctors. All of our teams are local. If we have any expats in those teams, then they have to speak the language and have been there for a very, very long time, so they are almost local. Sometimes they're not local than the locals. But after 18 months, 1,400 pages of documentation to try and open a couple of polyclinics, we had to go through 2 rounds of getting signatures through the government as a foreign direct investor. The 46th signature was the local cancer leader effectively, and it just made it very apparent that his figure was $50,000. And of course, every day we're bleeding money because you cannot move forward. You have to have a fully equipped, fully staffed clinic in Vietnam. It has to be opened, and they can then take as long as they want to then approve that before you can actually do any business. So you're paying the rental of your salaries, your equipment has gone in, so you're over a barrel. I'm fortunate that I was backed by a billionaire, a very sensible one, and we just said, fine, we're not willing to do that. We took the case right up to the level. But, you know, example of maybe a failure, maybe not, maybe something to learn from, and I think they now maybe regret they didn't do more for us, and they're certainly asking us to come back in. We had huge problems with regulation in India. We shut down 80 small clinics in Hyderabad and some areas there. And that was one regulation. In the end, there were plenty of other problems. These things are always more complex than they seem. In the end, regulation is what did it. We were earning more money from the pharmacy side of our clinics than we were from our clinical side because the footfalls hadn't ramped up over time. And therefore they said that you are really a pharmacist as opposed to a clinician. And as you are a foreign direct investor, that is illegal in India. And the law is grey. And there were various sums of money banded around to try and change that. So we just said, actually, we're not going to continue, let's focus our efforts somewhere else. You know, to the rest of Indonesia, we built out 140, we continue to build almost every day another generic pharmacy. We have 8 very high quality polyclinics across the central Jakarta. So again, sort of 5-10 doctor, mainly maternal focused, you go and see specialists. We have 1 diabetes centre, which we've built. It's a one-stop shop for diabetes. We see that as a huge problem going forwards. We've done that in partnership with our Filipino team, who've also just opened one in Metro Manila, but there's a significant problem with diabetes, a big killer in Kenya and in Egypt, we have maternity hospitals and chains of clinics, and we're currently doing a series of large acquisitions. So really what I'm trying to give is, like everyone around the table, and I agree with a lot of the points that have been made, there are all sorts of different solutions to do this. I think that everyone has a place, and I often use football as an example for this. I don't actually like football, I'm a rugby player, but if you know what that is, don't worry about it. I certainly won't use cricket, because no one will understand what I'm talking about. Some people, when they watch a football match or a fan of football, they read the score in the paper the next day. Some people might watch the game on TV at home and take out 2 hours. Some people might go down to the bar or the cafe with their friends to go and see the game, to get a little bit more time. Some, certainly in the north of England, will brave the wind, the snow, the sleet, and they'll go to the stadium and they'll watch that game. Okay, and that's an effort, certainly up in Newcastle. And finally, some people dedicate their lives to playing on the pitch. Now, all of those people are required to make football work. And just like you have a range of people in the sort of philanthropy, you could be a foundation, a philanthropist, a corporation, and all you do is you pick up the phone to your financial advisor once a year and say, I want to give X million dollars, X whatever it is, to charity. And that's the most you do. You can invest into an impact fund. You can be doing a little bit more, spending a bit more time, but you're going to your bank and saying, so what can we do? We'll invest in a social impact fund. And they'll invest into another fund, or invest into a business. Or you can fly to Nigeria and actually get on the ground and try and build your own business, get on the pitch as it were, and do it differently. So I think there's a range for everyone in this sort of world, and I don't think we should get too caught up in labelling and terminology. I think the big lack here is execution, and potentially a little bit of a fear of failure to go out there and do it, okay? And it's high risk, people have to accept that. You go into these countries, you use everything, and you're trying to do these things if you get it wrong. If you get it right, you can change the world. And that's what we're all here. So thank you very much.
Thank you, all panelists, for that very broad perspective on issues in health in Asia and other emerging markets. I guess before we turn it over to the audience for questions and comments, just in the spirit of what has been discussed this morning, I think it would be good to get some thoughts about whether you believe that healthcare receives its appropriate share of venture philanthropy, social impact investment, and if it doesn't, what is it that we need to do to ensure that innovative approaches to dealing with these issues are supported in the way they need to be? Who'd like to kick off? Amir, you raised the very same question, I think, in your presentation.
Yeah. The answer is a big yes. The healthcare does not receive the attention it needs to, for a variety of good and bad reasons. I think, to be fair, it is a complicated scientific issue, and most people just fight shy of that. Politically, health suffers from a lot of jurisdictional issues, and some of those are what Viva faces in Hyderabad, for example. And just the sheer inability to even set up basic healthcare facilities which come under tremendous amounts of regulation. But by far, the single biggest problem that I see, Stephen, on healthcare is that, given its nature, everybody is an expert on healthcare. Having been a patient once, I become an expert. So therefore, I know what is right, and that's why you will find huge amounts of battles against what are very simple practices. We fight battles against immunization across the world, where people think that immunizing somebody will cause death, impotency, whatever, and therefore children should not be immunized. And that's how we lose out on something that could very quickly deliver healthcare to a large number.
Other comments?
I think the argument also applies to Singapore, it's not just the developing, all this dismal state of affairs. If you look at it in Singapore, our Ministry of Health budget for this year is 5.7 million. For the Ministry of Education is 11.6 million, it's double. So in a way, it's quite congruent to some of the ratios that I saw down there in developing countries. So and in terms of the, even in Singapore itself, the payment burden on the government is slightly about 1/3. Whereas in developed countries itself, the government is shouldering anything from 60 to 80% itself. So of course, even right now within the Singapore community, they're just asking the ministry, the government to do more important things. But I think it's not just about the absolute quantity also. We must also look at how is it being deployed. In this case itself, I think like what Josephine has been doing in our interest in water and sanitation, although it's not very sexy, but I think upstream and preventive work is very critical to the healthcare agenda itself. And there's also onus on the part of the philanthropic community to look harder. Sometimes you just see, you have to really go down there to explore, to find, there's bound to be opportunities for you to be able to add value.
I completely agree, and I think that you should look at Asia with two lenses sometimes. You have developed markets and less developed markets. And within those less developed markets, they're often very regional, so state by state. And I think that particularly applies in India and sometimes in Pakistan and Bangladesh as well, and in China. And they have very different problems. They still have the same needs, but they have very different problems. And you have very different types of diseases, as was pointed out earlier. I think what the Lien Foundation has been doing in Singapore, and when you're looking at things like, well, there isn't really a business model, so not everything has a business model behind it. I may get that impression sometimes. But if you're dealing with mental health, and I think if you're dealing with elderly care, and you're dealing especially with autistic children, that's something where really I think philanthropists have to lead, and somewhere where the government can then follow, which I think is what has occurred in Singapore with the Lien Foundation. However, I'd caveat that slightly, that if you have a problem, a health issue in America, London, Brazil, wherever it might be, it's going to be exactly the same if you've got a bad stomach or diabetes or whatever it might be. The treatment is exactly the same in Hyderabad or Ho Chi Minh. And what was being made earlier about, the point being made earlier about IT and protocols is actually valid. You can make healthcare far cheaper than it is, you can make it far more relevant and far more scalable just by applying a different mindset to what is already there. The machinery can become less expensive. Utilising excellent protocols improves quality enormously, and there's huge studies done on that. So you can do this, and that's really what we're trying to do by going into the aspiring middle class, anchoring a business there, seeing what works, and then seeing how to make it cheaper. And people are doing this, and that's really where the focus needs to be.
My only comment is not really And it feels as if you speak to a lot of poor families about what they do with their money, most of them will try and put it into their children. It's a very human thing to want to give your children the best future, and the parents will typically go without things because they want to give their children an education. I think what we're seeing to some extent is that universal desire to try and give the best in it. What perhaps people are not understanding is that we need to deliver the whole package. So that's not an excuse, it's just an explanation. If you talk to people about how they spend the household dollar, it's always going to be, I want to make sure that my son, and hopefully now my daughter as well, will get the best education. I think the governments feel the need to improve that, but the health side of it is having such appalling consequences for anyone who's running around. You can see it's a tremendous cost, and we've now got in China the one-child policy, so how on earth they're going to deal with that burden is the problem, I think, that's keeping the government awake at night, because they may be highly educated, but there's going to be a huge health consequences with an aging population that's suffering so many chronic diseases.
Okay, well, thank you very much. So I think we can open to questions or comments from the audience.
Hi, I've been in Vietnam, and John mentioned corruption, and from my perspective in healthcare, that seems to be the biggest barrier. It's hard for many donors who want to get involved and who have gotten involved in healthcare activities, and they walk away very disgusted. I don't know if that's happening in other countries, but how do you overcome that barrier? Aside from doing your own projects, if everybody's doing their own project, that will not overcome the issue. It seems to me there needs to be involved to really run the system. So I'm curious about other countries now and any success stories.
The one heartening aspect of this is that corruption matters to health as much as it matters to education and agriculture. It's not peculiar to healthcare. Last year, I'm talking of the geographies that we work in, which is Africa and India, Pakistan, Bangladesh. We faced exactly the same problem whether we worked in education or in agriculture or in health. The only difference was that what's happened in the recent past is because of this large pressure on the spend on health. Then each country is trying to, post MPG, that everybody trying to put that extra money into healthcare government. And therefore you will find that the rate of increase of corruption in healthcare is more than in education or agriculture. In some cases, like in northern India, it has resulted in some deaths and killings of some officers and so on. So it's been in the news. But corruption is rather secular.
Corruption is endemic in any developing countries that we operate in. There will always be leakage. The question is the degree of the leakage that we can tolerate itself. And I can understand, like for example, Vietnam itself. I read about this surgeon, he did overtime, additional 5 hours surgery at night. And his additional pay for that was only $3 itself. So in a way, I'm trying to empathize the kind of situation. After the hospital project, it's infrastructure based, and this is still ongoing itself. We are still continuing to maintain the system, provide the services. And over the years, we have done 15 hospitals and another 40 over medical clinics all over Southeast Asia, many schools itself. Again, in terms of our approach when dealing with the officials, again, as we are flying the Singapore brand, the foundation itself, we are transparent. As say, I'm not interested in all this liquor and all this official loan itself. So you make your stance. Make it aware, make it transparent to the other parties that you give it. And you also notice over time, they also will respect you for that. Don't waste time. Let's cut the BS, let's put out the business we are trying. And in any case, projects dealing with water and sanitation is actually small budget compared to the road building and the mega infrastructure. So even if we talk about corruption, the potential opportunity now is not that significant. That's how I look at it.
Just to add to that, one of the serious issues that we are facing is that in the medical field, in some of these countries that I talk about, there is really a lack of standards in government agree that, for example, in India for the last 15 years we've been trying to get a bill on clinical standards passed. and getting the doctors to agree that they should be part of some consumer law that allows for people to file negligence charges. That's not allowed. So that lobby is very strong. That's one major reason why corruption exists there.
Firstly, please don't think that I in any way I'm saying Vietnam and India are places where you can't do business. Absolutely not. Everywhere it's difficult to do business, and I think that corruption is endemic. I think where we have failed has probably been partly a failure on us to have the wrong people and sometimes met the wrong people. But the only times we've really pulled out is where there is a complete impasse, where you meet someone who is absolutely no way, I don't care what you're trying to do in this country, I want my X amount of dollars. And that's the only time we've ever done that. So that's really one individual, and it's not typical of those countries. I think the point around pay for both education and healthcare, until you have the right amount of pay and the right amount of government focus on your public sector health, I personally think that this is going to be a huge issue in South Asia, Southeast Asia, where you have hundreds of millions, if not billions of people who have all got access to the internet now. It's very similar to the Arab Spring. They are all beginning to move into urbanized areas. They can all watch House MD and see what good healthcare looks like, walk down to the one luxury hospital that may be there, and they've got some money to spend. And I think that in years to come, maybe not now, but in 5 to 10 years' time, people actually get quite angry. There isn't the infrastructure there, it takes time to build, and that's really the issue in South Asia and Southeast Asia. The infrastructure is not there. And there aren't the right clinics, there aren't enough hospital beds, there aren't enough, schools and the rest of it. So people get cross about that over time unless there is an urgent move on it. And that will take government involvement. So in terms of have I encountered it elsewhere, yes, I'm very fortunate that I've had a very good pitch. I'm coming to a country to build infrastructure you don't have. And if you're a politician, that always sounds good. I'm not going to take any money out of your country. I'm purely here to train up the people of your country, and my team is all local. Okay? And we will persevere to give us some support, and you can do that from the ministers all the way down. I generally do not approach ministers. I generally start sort of under the radar and in the slum areas and out of the rural areas, and we do it very quietly. So you can avoid that because most people are good people, they don't want the whole sort of corruption shebang that goes with it. And to give an example, in Indonesia, I have a great guy who's in Indonesia, and what he does is purely community relations before we go and put in a clinic somewhere. So he goes to the mosque and he speaks to the imam. He says, this is what we're trying to do, takes him through it. He'll go to the local brothel, he'll speak to the local brothel owner and say, this is what we're trying to do. He'll go to the gang owner and say, this is what we're trying to do. The school teacher, the council leader, and say, this is what we're trying to do. We're trying to do some good here. Do you support us? How can we help? What is it you'd want from us? Not in terms of money. And nearly always the response is overwhelmingly positive. Wow, this is amazing. Someone's taking an interest in trying to help our people. So you can get around it. You have to have the right approach. You have to have the right people. And you have to understand the culture of that country. And going in, flying in from New York or Singapore is not always the best way, is my view. So I try and stay here a bit more.
You asked for a good news story. The last time I was up there, which was April, we went into the village, the township with that horrible bathhouse I showed you. We have a local relationship guy. He arranged for us to go and see the deputy mayor. And we went into the boardroom of I call it a boardroom. It had a no smoking sign on it. And there was a young guy there, and he had a file of papers with data on it. And that was the deputy mayor. And I thought, fantastic. I've been to so many meetings where you get someone who's just interested in you taking around and drinking lots of baijiu. Here was somebody who was professional, prepared, interested. So, and definitely no sleaze factor. Usually if there's a sleaze factor, you're just going to retire gracefully. We are not in any way able to cope with that. But I do see a change as we see, China is very concerned about corruption, and the message sometimes gets through to the right area. You find someone that you can do business with.
Thank you. Other questions, comments?
Yes, good afternoon. Steven from the European Venture Philanthropy Association. I have a question. Within health, what gap does venture philanthropy feel that traditional philanthropy or traditional investments do not fill at this stage?
Very good question.
Huge areas. For example, most of these neglected diseases, on the sanitation issue, take the fact that that Stephen pointed out that half the population here has no access to sanitation. Take India, 70% of India has no access to toilets. and much of the reason is important. So the question often asked is that why should the toilet technology be so water dependent? Why have we not done any innovation on something that we use every day? The last invention on sanitation was somewhere in the 19th century. So what we are doing, for example, at the Gates Foundation is spending a bunch of money, close to $1 billion, on a new reinvented toilet that will be of use in areas which do not get water. So venture philanthropy in the health sector must therefore get into areas that are totally neglected. If you see any data, you will find that inordinate amounts of money going to cancer and diabetes and so on. What are the rich men's diseases? But we've done really nothing on malaria, for example, for the last 30-40 years. So that's one very simple answer. That upstream in public health areas, in innovation and in drug discovery for medicines where no research has been carried out for the last 40-50 years. On sanitation, drinking water. There is very little work that is done on those issues, on cheap sources of drinking water. You can get purified drinking water, but it's way too expensive for the poor to leverage that. So there are just any number of issues that are available for venture philanthropy to get into. Obviously, these are high risk. Obviously, these will have 10 failures to 1 success, but that's exactly what makes this sector exciting.
You asked what impact. I mean, we do talk about venture philanthropy as different because it has a focus, it has people with business backgrounds, they come up with a plan, they come up with a green milestone. So you attack a problem rather than just sort of throwing things at it till it's sort of better. You've got an idea. For us, it was we're going to run a bathhouse, we want it to be profitable. I've done private equity, my friends have run restaurants, and it's like we had an idea about what should happen. And so you come at it with a plan and with outcomes and monitoring it. And I think that does produce a result. So I think there is a value in what venture philanthropy does over traditional philanthropy, which is I'm going to give you some money and it will make you feel good. So if you go around China, you will see many schools that have been built and not operated. You will see facilities that have been built and not operated because philanthropy put them up, but didn't actually think about what happened once they were open. And I think that's a big difference in the way that venture philanthropy will attack a problem. It's not just putting up the infrastructure, handing it over to the community and expecting them to run it. It's also engaging with them to develop longer-term solutions.
I am someone with find discontent or less unrest when you look at social issues and stuff. So my simple answer to your question is there's too many. Because venture philanthropy is a catch-all term. And even put in the context of some of the causes to look at this end of life. What is a national challenge here in Singapore and elsewhere? At the end of the day, is how can we enhance access, quality, affordability, choice, equity to the delivery of end-of-life care, regardless of background, diagnosis, or setting. I think that kind of question can be applied to all issues, all diseases. We just need to peer harder and in a way want to do something about it. If I may quote Bruce Lee, he's one of my heroes. It's not willing is not knowing is not enough. You got to apply. Willing is not enough. You got to do. So it's only when you start to do that you learn more and you can refine, you can do more sophisticated projects. Whether whichever venture philanthropy or form or whatever you're contributing.
Maybe just one other comment from me on that issue about what venture philanthropy or social impact investment might specifically have to offer. I mean, I think there has been, and there probably still is to a large degree, an expectation that healthcare is primarily a government matter. Governments provide healthcare. It's very apparent that they don't. I mean, whilst they may try, the quality of the service that has been delivered across much of the emerging markets is absolutely substandard. And without wanting to be unduly critical of governments and philanthropic organisations that deliver care, it isn't enough. And so I think there is really a very important area and a new area, which is investment in social enterprises that are going to deliver value in healthcare, and that's both services, So, for example, I mean, that's what John's organisation is specifically doing. But I believe in drug development and technology that there is also a specific place for social investment to make new products for these markets where there are no other commercial players. I mean, most commercial players still are primarily interested in products for the established markets and expect some trickle down when they go off patent. But there are very few people thinking of fit-for-purpose solutions for these markets, and I think that's a critical place that venture philanthropy or social impact investment might play a role. So any closing comments that anyone would like to make? Have we said everything that we need to? Well, I'd like to thank you all for a very stimulating session. Such a very broad perspective from bathhouses to cancer hospitals. And, you know, I mean, indeed, it does reflect the reality of public health to end-of-life care. And thank you all for being with us and for your contributions as well.